Chapter 6, we have pleural effusion, sleep apnea, bronchopulmonary aspergillosis, and the Department of Miscellaneous Department. Yeah, they're too short for single chapters. Now, you need to know what's sometimes known as Light's criteria. This is one of the upgrades to the book between editions. We expanded this section. You are definitely asked, step 3, and it's an educational objective, that you should understand what's the difference between cancers. Cancers and big infections are thicker and richer and creamier. It's like mushroom soup. So infections and cancers have more protein and more LDH. That's about it. So for all pleural effusions, first you get a chest x-ray, and then you get decubitus films, and you lie them around, see if it's moving, see if it's moving. Is the fluid flowing? Let it flow, let it flow, let it flow. Oh, the fluid inside my chest is frightening, and Light's criteria surely, yes. So the thing is move that fluid around, and that'll tell you whether you need to tap it. The chest x-ray adds a little more detail. The other thing about the chest CT adds a little more detail. The other thing about the chest CT is that it helps you to know, like I had this, I knew I was making this, and interestingly, patients do me the good favors of getting admitted to the hospital under my service the day before I'm about to film something out here that's new. And so I had a lady who came in with a brand new pleural effusion, and we're going to tap her, brand new pleural effusion, except I said, well, let's get the chest CT. Well, what do you want to get a chest CT for if you're going to tap her? We know that's going to tap her. She's got a fluid. Because if there's a mass in there, if there's a mass on the CT, you need bronchoscopy. And so consequently, you don't need to do the pleural tap, because if there's a lesion in the lung seen on CT, you need bronchoscopy or another form of lung parenchymal biopsy, and that is more accurate than doing pleural fluid analysis. So the chest CT gives you some information on, is there a lung lesion that needs to be biopsied, because between the choices of tap the chest for thoracentesis and analysis of cytology versus biopsy of the lung for the lung mass, the biopsy for the lung mass is clearly more accurate. The most accurate for pleural fluid is thoracentesis, but if it's from a lung lesion, it's much better to rely on lung biopsy than to rely on cytology of pleural fluid. You see, if there's a mass in there that we can see, or there's some other mass up in there, it's better to get a chest CT and see what's in there and biopsy the mass. This one, Helen Keller could biopsy that one, right? Now, you see the effusion that's loculated in there. See, if there's no mass in there, then it's good to go and take a sample. Cancers have higher proteins. Cancers have higher proteins. Cancers have higher LDH. Cancer and infection have high protein and high LDH. Transudate basically means congestive failure. Now, the protein and LDH can't tell you by itself that this is a person who's got an infection or cancer. The infection is determined not just off the higher higher protein and higher LDH, but a cell count, white count high, and what tells the empyema, the girl from empyema. That's not what that means, the girl from empyema. How do you tell it's the girl from empyema? And the answer is pH. If the cell count is high, over 1 or 2,000, over 500 for sure, under 500, no infection. Over 1 or 2,000, infection. And the pH low. That pH low is more accurate than even the stain in the culture. More accurate than acid-fast stain. More accurate in terms of infection. More accurate than LDH. But cell count and pH tells you there's an empyema. Cell count high and pH low. pH of 7.2 or less means you've got an empyema. 7.2 doesn't sound so bad, right? That's because most people don't know what's the normal pH of pleural fluid. Do you know? Do you know what it is? The normal pH of pleural fluid? It's 7.6. Really? 7.6? It is. It's 7.6. 7.6 is the normal pleural fluid. That's why a pH of 7.2 in pleural fluid is like a pH of 7.0 in blood. 7.2 is a disaster in the lungs because the normal pleural fluid pH is more alkalotic than blood. Small effusions, normal fluid pH is more alkalotic than blood. Small effusions don't need any therapy. You can use diuretics, correct the underlying cause. You can drain it out, correct the underlying cause. Now what happens if you drain it, pull out the tube, reaccumulates. Drain it again, pull out the tube, reaccumulates. Or you say, man, I got cancer in there and that cancer's not going away. It's like, look, doctor, first of all, your chest tube sucks, it hurts. Second is it keeps reaccumulating. The third is I've got lung cancer and I don't want to spend the last 6 months of my life in the hospital, okay? So pleurodesis. Pleurodesis seals up pleural space. Pleurodesis. Put an infusion of an irritative agent like bleomycin or talcum powder or doxycycline into the pleural space, and it inflames it, and then the pleura literally stick to each other. Now this has got to feel wonderful, right? It's like, why don't we just pour acid into your pleural space? And the answer is we pretty much almost do. Pouring talcum powder into your pleural space? Holy crap, man! Yeah. Oof. Yeah. And that's that's to seal it up. It's pleurodesis means to seal up the pleural space. I know, as if having lung cancer wasn't bad enough, right? Now, what happens if pleurodesis doesn't work? Sometimes people have such large effusions or such rapidly accumulating ones that you can't get the two layers to stick between the visceral and the parietal pleura. What happens when you have such large effusion you can't get the stick because there's fluids in there? You decorticate it. It literally means you strip the pleura away. You strip the pleura off, like peeling an orange. And it sticks together. Pleural fluid, LDH high, protein high, cancer or infection. If the cell count is high, over 1 or 2,000, pH low, it's infection. Chest tube if it's big. Our next subject is sleep apnea. Okay, wake up. I'm having daytime somnolence. Yes, it's obese people. It's going to be more and more common. Daytime somnolence because they're suffocating during the night, so they don't get any rest. You don't get any rest because literally what happens is you get interrupted during your sleep because you're in the process of suffocating to death. You have severe snoring because you're suffocating to death. And these are things that we're not quite clear why you get, but you get them. Why do you get hypertension? Oh, we think sympathetic hyperexcitability. We don't know, but you get it. Why do you get erectile dysfunction? Don't know. You get erectile dysfunction. Headache, probably because there's a reactive vasodilation. I'm making it up because how do we know? What are we looking at your brain vessels while you're asleep? We don't know. So hypertension, headache, erectile dysfunction are all things that are standard and you should expect them in sleep apnea. And you say to the guy, listen, even if you don't want to make your wife happy because you're snoring all the time, if you get your fat neck fixed or you use CPAP, you'll have an erection again. And you go, but yes, doctor, if I have the CPAP on me, who's going to want to have sex with me anyway? Good point. All right, so the thing is with sleep apnea, 95% of the time it's from obstructive sleep apnea, and very little of it's central. Central is a drag. You can't do too much about central. Obesity-related obstructive sleep apnea is so common it's on infomercials on TV now. So sleep apnea has hit the realm of common knowledge for the average TV-watching fat person and have CPAP machines at home. The sleep apneas that are central are very hard to control because we don't have anything really to drive central respiratory drive. So we give people progesterone, theophylline to try and do central drive, progesterone and theophylline. It doesn't work too well. Now, as a diagnostic testing for sleep apnea, polysomnography, isn't that a fantastic name for going to sleep in a lab somewhere? It's fantastic. Go to sleep in a lab somewhere. Polysomnography, sleep studies. Okay, you basically sleep in a lab and we measure how often you have periods of apnea and hypopnea. Isn't that a great word? Hypopnea. Okay, hypopnea. Man, so it's like a short pope. It's like a decreased poping. And that's the difference with the opposite of tachypnea. Dyspnea, difficulty breathing. Hypopnea, it's like bradypopnea, Brady breathing. And you look for these, and by definition, they're defined as a period of lasting 10 seconds. Well, you guys say, well, you mean somebody who has got a less respiratory rate of 6? Yeah, that's what it is. In other words, when you're asleep, you can go down a respiratory rate of 7, 8, 10 routinely. During the daytime, your respiratory rate is 12, 14, 16, 12, 16, 12, 14, 16. When you go to sleep, it's 7, 8, 8, 9, 10. But if your respiratory rate goes down to 4, that's too slow. That's too slow. And those are apneic episodes. And you monitor your saturation. So we basically say, okay, how many of these episodes are you having per hour of apnea and hypopnea? How many of these episodes per hour are you having where you have a greater than 10-second pause in your breathing? And I always wonder, how can people go to sleep in these sleep labs? I can't even sleep in my own house half the time. I don't know, stay up writing USMLE books. So what do? Well, the thing is that people do. They go to sleep there. They go to sleep. They may have to wait an hour, but they do, in fact, go to sleep. Okay, so it's if you like being watched by cameras while you're asleep, that is. Okay, so what the thing is that a matter of severity is saying, well, more than 30 of these an hour, basically 1 every 2 minutes. Ooh, that's a picture of polysomnography. Isn't that interesting? It is. Looks like a bunch of squiggles, doesn't it? Well, the whole point is it's actually measuring your saturation, your oxygen saturation. It's actually measuring what your amount of oxygen that you're breathing in is, the FiO2, and taking a look at the pauses in your breathing. Now, the treatment for central, we don't have much for central sleep apnea. Progesterone, theophylline makes you breathe faster. And the other thing is CPAP and BiPAP for the obstructive disease. First of all, we try and get the fat off your fat neck. That's logical, right? The other thing is don't drink a lot, don't use the bed for things except sleeping and other extracurricular activities. But the point is, people who have difficulty with this should not be using their bed for general TV watching and hanging out, reading their books. And so this way, you lose weight and try and trim down that fat neck of yours, and CPAP and BiPAP. Now, BiPAP means that you get a slightly higher pressure during the inhalation. BiPAP means that you get 2 levels of oxygen pressure. You get a higher pressure during the inhalation than you do during the exhalation, all to keep your uvula out of the way. Now, if it's not effective, the other options besides oral prostheses, literally to keep your uvula out of the way, that you can actually put in your mouth when you sleep. Holy crap, look at that airway. You can intubate me without a speculum. Okay, without a laryngoscope. And so for people who don't respond to CPAP and BiPAP and weight loss and stop drinking before they go to sleep, we have a uvulopalato-pharyngoplasty. Uvulopalato-pharyngoplasty? Wow, what does that mean? It means they take you to the operating room and they basically core out the inner part of your throat, trying to unblock that thing. Wow, I'll take the CPAP and the BiPAP. So for central sleep apnea, no drinking or sedatives, and acetazolamide increases urinary excretion, bicarb, because carbonic anhydrase increases urinary absorption of bicarb. Carbonic anhydrase increases urinary absorption of bicarb. So acetazolamide helps you excrete the bicarb. Acetazolamide helps you excrete the bicarb. So therefore, the metabolic acidosis helps drive respiration. Acetazolamide blocks carbonic anhydrase. If you block carbonic anhydrase, you excrete bicarb in the urine. If you excrete bicarb in the urine, you have more acid in the blood, which helps drive your central respiratory stimulation in the brainstem. Medroxyprogesterone, because female sex hormones make people breathe faster. Next subject is allergic bronchopulmonary aspergillosis. It's a good name, right? Good name, pretty clear from the name, right? What's it from? I don't know, but it's a lung problem and it's from aspergillus and you're allergic to aspergillus. Yes, absolutely, it's a good name. It's a good name. It's a little hard to diagnose and generally it colonizes people who are asthmatic and it gives you worse asthmatic symptoms and you get these fleeting infiltrates. You cough up brown mucus plugs and you get infiltrates that come and go and they're here and they're there and they're here and they're there and they seem to change spots, change locations. They seem to actually change recurrent infiltrates in different locations, brown mucus plugs. Now, allergic bronchopulmonary aspergillosis is a little difficult to make a diagnosis of because there's no really good blood test and just culturing sputum for fungus is not a great idea. It's not a great idea because there's you don't find it a lot. It's not in that great a density. So there is eosinophilia, so you're allergic, and that's why it's called allergic bronchopulmonary aspergillosis, because you're showing signs of allergy, like eosinophils and IgE, like eosinophils and IgE, like eosinophils and IgE, like eosinophils and IgE, like eosinophils and IgE. And bronchiectasis occurs, but the thing is we have some specific diagnostic tests of looking for Aspergillus precipitans. Now, Aspergillus skin testing is okay, it's fair, but I hate to tell you this, but there's not going to be one test only for allergic bronchopulmonary aspergillosis. There's not. I wish there was one test for allergic bronchopulmonary aspergillosis, but there's not. We have IgE levels, Aspergillus skin testing, and here's one of my favorite ones, circulating Aspergillus precipitans. Aspergillus precipitans. Now, if there was one test, I'd tell it to you. If this is a CCS case, I try and order all of these, particularly the IgEs and the circulating precipitants and the Aspergillus fumigatus antibodies. Now, the weird thing about this is you would think that inhaled steroids would work. And if I wasn't me, I would think that inhaled steroids would work. And before I became Conrad Fisher, you would have said inhaled steroids. But inhaled steroids are not strong enough for allergic bronchopulmonary aspergillosis. You hear that out there? Allergic bronchopulmonary aspergillosis, you need systemic steroids. And since step 3 asks route of administration, it becomes an issue, right? That if you answer inhaled steroids for allergic bronchopulmonary aspergillosis, easy mistake to make because after all, it's not invasive. It's mucosal irritation. I would make that mistake. Don't do it. It's oral steroids. And itraconazole is a drug that sort of never took on, became sort of like the cassette tape player of infectious disease. And the 8-track tape player of infectious disease was out for a while, never really got big. Voriconazole is the number one drug for all forms of invasive aspergillus. And if you have invasive aspergillus in the lungs, but even a neutropenic person, voriconazole beats amphotericin. Voriconazole beats amphotericin. Matter of fact, voriconazole and caspofungin, the echinocandins, both beat amphotericin. Which one? Efficacy or adverse effects? Both. Voriconazole, the echinocandins, which is caspofungin, micafungin, and adulafungin, caspofungin, micafungin, and adulafungin, are all better than amphotericin. The only two indications left for amphotericin are Cryptococcus, because it misses the echinocandins, miss it, and mucormycosis, black mold fungus ripping through your skull in an out of control diabetic. This is not a routine use of these medications for aspergillus. If you have the person, you start the steroids and they don't get better, then you start the antifungals. When you bring them back in a week, 2 weeks, and it says interval history, the how you doing button, interval history, patient reports continued shortness of breath, continued cough, continued brown flecks of sputum, voriconazole, itraconazole. Is the end of chapter 6, and we will see you in the next section.